This is Alissa.
And this is Chelsea.
Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Unfortunately, Caroline and Evie were unable to join us today. Alissa, what's going on with you?
It feels like the 875th day of March. So still dealing with some of the COVID things, constantly watching the high school dashboard where my son's going to find out whether or not he's going to be sent back home. My 85-year-old neighbor passed away yesterday. That was kind of a weird experience, to be honest, because of the way the family approached us. It was just kind of like, hey, Vern died, watch the house. And we were just like, what? Vern died? What do you mean Vern died? So, I mean, that was kind of a weird experience. It's just COVID everywhere, whether it's at home or at work. Our governor has asked us to go on a lockdown. My employer has asked us to go on a lockdown. And so we're pretty much isolating again with like no end in sight. I know it's probably not something anyone really wants to hear, but what about you? Something amazing going on in your life?
Just basically trying to find, the little spots and moments of joy. So some things that have been occupying my time lately, I've recently learned how to trade options on the stock market. So that's been pretty cool and a different way to make a little extra dough. And I've also been learning how to code. I don't know if I think I might have told you guys this before. Code Academy is a pretty cool website to learn how to code. Currently learning JavaScript, very new to coding. But I love it. And I love also trading options and just learning different indicators, just kind of nerding out on those two things have really made me happy. And then I will also be 27 in 2 days.
Woo-hoo.
So happy pre-birthday to me.
Yeah.
Very much forward looking to celebrating myself and just being just so grateful, kind of a posture of gratitude towards turning 27 this year, because it really could have been, another way as a nurse on the front line caring for COVID patients. So I'm just extremely grateful to be here, ready to see what this next year holds.
That's something I really admire about you, Chelsea, is every time we do this check-in, you are so good at talking about the gratitude and the positive things that you're trying to do to stay on the positive end of this experience that we've been going through. And it's been harder for some of us to do that. And so I really appreciate checking in with you to get kind of like that other side of things and kind of remind me of the things that I should be grateful for and not always focusing on the struggle and how difficult things have been. Because if 2020 has showed us anything, it really should show us the things that we should be grateful for. So I appreciate you always kind of helping me flip things around and see things from the other side, because we need that. We need that positive light. We need that person in our life that's going to help us, like, don't take life for granted, look for the positive things. The fact that you're always doing that self-improvement, looking for the coding, looking for ways to continue to learn and grow. I am doing that, but I don't look at it like that. I've been working on my PhD this year and it's amazing and I love it. And, I'm geeking out in all of my classes, but when it's like, hey, what's new? Like, that's not the first thing that comes to mind of like how much I'm growing and learning in my program. It's how frustrated I am with my life circumstance. So I just want to thank you, because I really do appreciate how much you look for the things to be positive about and have gratitude over.
Yeah, of course. And thank you for seeing that. It's not easy. And anyone that's listening, it's so hard. I've been dealing with some issues with depression for a while, but kind of with COVID and everything, and obviously the election and everything that's been going on, just kind of just stacked against me. And I had to reach out for professional help. And I'm really proud of myself for getting that first counseling session in and then talking with my doctor about getting an antidepressant on board. It's not easy. It's so hard, but I'm really grateful that I have those resources available and that I have the ability, with so much help from my family and my friends, to kind of tap in and get to the other side of everything that I've been going through lately. So If you need
Absolutely.
help, or if you find yourself in a dark place, please reach out for help. Please don't feel like that you're alone, because all those feelings can be so isolating. But
Absolutely.
just definitely try to reach out an arm and have someone pull you to the other side.
No, I think that's great. And I think it's amazing that you're willing to share that. I also have had an increase in anxieties, and that's something that I've had to reach out and ask for help with my healthcare professionals, because this has been a really difficult year with a pandemic. And then we had our earthquake, and then we've continued to have the rise in the peaks, the election, this year has just been horrible, which is why it is really hard for me sometimes to look for that silver lining. And I'm so grateful when we do these check-ins, and that is exactly what you go for, is that silver lining. So like I said, I'm appreciative.
I love you too, Alissa.
Love you, man. Yep.
All right,
Good
guys.
talk. I know,
So we're
right?
supposed to be talking about pain management today.
We should be. Instead, we're broing out. It's fine. Yes, pain management. Let's talk about it. Pain management has evolved a lot over my nursing career. I don't know about you, Chelsea.
It has, especially with the opioid crisis.
Yes.
Pain management used to be one of those things that kind of flew under the radar, but you've seen over the past few years, especially with an increase in palliative care, complex regional pain syndrome diagnoses being on the rise. That's for me and my experiences with being at the bedside. Pain management has definitely taken on a new definition.
Absolutely. So my bedside experience is ortho surgery and trauma, right? So a lot of pain management in those areas. And I remember being a brand new nurse on the floor and having these in-services with our pharmacy, our floor pharmacist telling us how to manage the pain, and then citing the research that, less than 1% of people become addicted to opiates, and that we should be educating our patients so that they're not afraid to take their pain medication. And reflecting back on that period of time and how I was educating my patients based on that information coming from a trusted source, right? My floor pharmacist, whom you go to them for any of your medication issues. So reflecting back on that, and then fast forward to when I found out that the study that everyone was citing was false and fraudulent and based on bad data. And one study that a doctor did in his office, bad study altogether, I felt like a fraud. I felt so lied to by my medical community. And then I felt like I contributed to the problem. When I think about all the patients that I gave that information to try and help comfort them so that they would take their pain medication, and then did I contribute to a problem they might have had down the road? You know what I mean?
I totally see what you're saying. And then there's always that thin line between managing someone's pain and then having a patient that is or has had issues with a dependency on opioids or other addictive issues. So that's always a challenge for me, especially when you connect the dots to those patients being the ones that threaten to leave AMA if they're not giving the opioids that they want or the opioids of their choice. Pain is subjective, and we are taught in nursing school that pain is what the patient says it is. And then we're also taught in nursing school that pain is a vital sign. That's one of the first things you do with your shift assessment is, are you in pain? Where is it? What's the nature of the pain? How is it usually relieved? Is it new? How long has it been going? I mean, there's so many questions related to pain. And then obviously pain management helps to influence patient experience and also trajectory for our patients. How well are they going to mobilize with their current pain regimen? So
Oh,
there's so
absolutely.
much that goes into it that I think that we don't even realize how much we're putting into pain assessments at any given moment.
No, I completely agree. And it's interesting when you think about, well, at least for me, over my practice, it went from make sure you're educating your patients so they take their meds, because if they're taking their medication, they're more likely to get up and perform with physical therapy and do the things that we're asking them to do. But there really is that shift or that concern that the patient will no longer be in pain, but they will still take the medication because their body is telling them to. And what I mean by that is that studies have since come out showing that patients who are on long-term opioids no longer receive the signal from the pain in the body. They start receiving the signal from the medication themselves, telling them that they're in more pain than they really are. And that's concerning, right? So now we get these long-term chronic pain patients coming in for acute on chronic pain, and we cannot manage their pain because they feel like they're in more pain than they are to start with. And then they have an acute pain episode on top of it. And so managing these patients' pain becomes unmanageable. I have some personal experience with this. My husband was a chronic pain patient for about 10 years. And this was before I became a nurse is when he was injured. And then it was through the beginning of my nursing career. And it was as we became more educated and more aware of the studies, we took him off of his narcotics, and he learned that his pain wasn't as bad as he thought it was. And it was really interesting seeing that transformation. So now my husband's had 4 back surgeries, and the most recent one was a spinal fusion, and he does not take narcotics at all. Whereas before, with his first surgery, which was a micro discectomy, he probably spent, I don't even know how many years on OxyContin, oxycodone, MSIR. I mean, they had him on everything. So it's interesting to me that as his procedures got bigger and bigger, but our education became better and better, we were able to manage his pain better. And ultimately, he no longer takes narcotics because they were causing part of the problem.
Yeah, that kind of reminds me of how difficult it is to do that with patients who aren't as educated about how opioids can negatively affect them. And my memory bank, the experiences I've had with opioid addicted patients, and how oftentimes we are not taught the signs and symptoms of opioid withdrawal, like a runny nose, all those other symptoms.
Right.
We think that our patient's just acting irrationally when they're actually going through an acute medical process of withdrawal, and how we're not taught to recognize that and how to kind of meet them halfway with that. So in my experiences, I really felt bad because looking back on some things like, wow, this patient was withdrawing from opioids and I didn't know that. And I didn't have the tools or the resources that I needed to be able to meet them halfway. So I think that's definitely something that we as nurses can start thinking about is, how can we meet our patients halfway without really kind of giving into demands that harm them?
A lot of our orthopedic surgeons will go and perform the same procedures in third world countries in Africa or South America or whatever. And the patients don't get any pain relief, or they'll get a Tylenol or something. One of the things that was really interesting for me to learn is that pain management is an American thing. Like narcotics is an American, I don't want to say right, but privilege is probably the better word. When the United States is consuming 80% of the narcotics in the world. And I don't remember the study, but that was something that was discussed in a narcotic meeting that I had participated in here at work. When they're talking about the United States is consuming the majority of the narcotics in the world, that is something that I find scary. It's part of our culture. It's part of the expectation that if I don't have to be inconvenienced with the pain, then we should make the pain go away. Other cultures in other countries across the world talk about pain is a part of the experience, and it guides you and your body in knowing if you're getting better or if you're getting worse, and managing those expectations of this is just going to hurt. You just need to deal, right? I didn't realize how much pain management was part of the culture. I thought that was just part of medical treatment. But like I said, you go practice somewhere else and it's completely different in terms of how they manage people's pain.
It's an interesting take, Alissa. Have you ever caught an opioid addicted patient self-medicating?
Yes, actually, we had a patient that was shooting up heroin in the bathroom. Actually, I could give you millions of examples. That's the one that comes straight to mind, though, is the patient that was doing heroin in the bathroom. I believe she was some sort of hip problem, and she kept shooting heroin into the hip, right? So she's already got an underlying issue, and then she's throwing heroin into the issue to make it worse. How we handled it was originally we put her on like a sitter, a close supervision, people watching it. Then we realized that it was a visitor who's bringing it in. So then that visitor got trespassed. But ultimately, it came down to the doctors having to discuss with this patient whether or not she wanted the treatment, because we were working so hard to get her better and she was pretty much doing everything she could to not get better, and smuggling drugs into the hospital and shooting them up in front of our staff and all that. I mean, that was not an atmosphere that we needed our healthcare workers to be in. And so I think they ended up having her do a behavior contract. And then after she received her care, she was discharged. We have found other patients who have their own stashes in the bed. It's that patient that won't get out of bed without their toiletry kit that they pack. Those patients are usually easier to spot because they are falling asleep, asking for pain medication as their drowsiness and their pain levels and all that don't really match the level of narcotics you've given them. And again, it's the same thing, right? You go through their belongings, you tell them that your suspicions, you ask them to comply, you explain the risk benefit analysis of over medicating them. And ultimately, it's behavior contracts or termination of service. How do you guys handle it in your place, Chelsea?
So we take a similar route. We actually have security come and do a sweep of the room so we can remove any other medications that may be at the bedside. We also kind of help try to mitigate this with the admission process, asking the patient, do you have any medications with you? And then actively going through things like saying, hey, can I look through your things just to make sure that you don't have any controlled substances? Because if you do, we're going to have to lock them up. So if you don't find anything there, then you do find that they have something, then getting security involved, making sure you complete proper documentation in Epic, and just making sure that you're covering all your bases with the adrenaline that comes with the situation. Like, oh my gosh, my patient has unauthorized drugs. It's getting a set of vital signs, like making sure that they are still stable, asking them to be honest about how much they've ingested, different things like that. I think people are kind of so upset when they find those substances at the bedside that they forget that there is a clinical aspect to this. We still need to make sure that our patient is stable.
Oh, absolutely. And the other thing about that, and this was something that I often did taking care of these patients that have the chronic pain or on the high pain medications, is you have to assess what their baseline doses are. Oftentimes when patients are admitted, there's a set pain management order that is placed in Epic or however your charting system works, but it's usually predetermined, right? You can pretty much guess like a new admit with this diagnosis is going to have this range or these orders for pain medicine. And when you have a patient who's coming in that has chronic pain and has been on narcotics for a long time, their tolerance is higher and their doses are probably higher. And so making sure that you're assessing that we're at least meeting their home dose so that we don't unintentionally put them into withdrawal. That's very important. If you are taking care of a patient who normally your order set is 5 to 15 of oxycodone and they're taking 20 to 40 at home and probably more 40 because they're in charge of it and they're not on a time schedule. They just take it whenever they want. They're probably over medicating themselves, but their body has a tolerance to it. And that can be scary for doctors and nurses to explore with a patient. But we also want to make sure we're not under medicating them. An acute trip to the hospital is not a good time to detox somebody from their pain medication regimen. So it's a really hard balance to try and make the good decisions for your patient, manage their pain, and not contribute to the problem.
Agreed. I think that's a good point that you raise is in the process of talking about pain management, we also want to make sure that we are addressing our patients' pain needs to the best of our ability, making sure that they do get adequate pain control for sure.
You know, and one thing that I've seen our pain care sets change over time is before it was very straightforward, 5 to 15 of oxycodone and some Tylenol on the side because we dealt with a lot of bone pain. So that was kind of like the dream cocktail for an ortho patient or a trauma patient. But I've seen over time, they're going more multimodal, less heavy narcotics, more let's throw in some tramadol, let's throw in anti-inflammatories if it's not contraindicated with what's going on with the patient. And then more non-pharmacological interventions. Let's get the patient up. Let's get them walking. Let's get them doing the things that are going to help them ultimately rehab and go home in the long run. And it seems like at least the doctors here have started becoming more comfortable with allowing their patients to be more uncomfortable, if that makes sense, because that's ultimately what the research and the literature is showing us. that opioids are in fact addictive and that we don't want to contribute to that problem, that they do have a time and a place, but it's in the patient's best interest to limit the amount that they rely on them and allow themselves to do the things they need to recover from their surgery in the best way possible.
I agree. I'm a huge advocate for multimodal ways to reduce pain. And it's really hard when you are, I don't know about you guys' setup, but at our hospital, the person in the A bed doesn't have a window view. It's just their half of the bed, the door into the room, and the TV. You don't know if it's day or night sitting on that side of the bed. So it's really hard. I really wish that our hospitals were a little bit more friendlier to our patients, especially our patients that suffer with delirium and pain issues, because it's so bleak when you're in there, when you're sitting in that bed 24 hours a day, 7 days a week. Some of our patients, especially with COVID, have been placement issues. So they're there for possibly up to a month in that same portion of their room, and then having limited access to where they can go in the hospital because of COVID. So all these things can really make your pain worse. Not being able to see your loved ones, not having the usual outlets that you have access to. So yeah, definitely making sure that if there's something that you haven't tapped in yet, like music therapy, something of that nature to help with your patient's pain, definitely explore those options.
Oh, absolutely. And there's always going back to basics with your nursing interventions with either heat or cold, depending on where the pain's coming from, if it's a surgical incision, et cetera, right? So fresh surgery incisions, we don't want to put heat on because that creates the breeding ground for bacteria. But a fresh surgical wound could appreciate some ice to help reduce the swelling, right? It doesn't have to be a narcotic to help reduce pain. Go back to what your mama tell you, like slap an ice pack on it or grab the heating pad or things like that. And ambulation, I think people really underestimate the power of ambulating, especially if you've had some sort of like abdominal surgery or something. You put your gut to sleep under anesthesia. You got to get up and get walking and get that rolling again. And so there's a lot of nursing interventions that can help the patient to find a more comfortable way, more comfortable positions. But the expectation of the patient is that you're just going to give me a pill or you're going to give me a shot and it's going to make it go away. So I think a large part of pain management is also managing the patient's expectations. We're not going to take your pain away. That's not my goal. That might be your goal, patient, but my goal is not to take your pain away. My goal is to try and make you be able to do the things I need you to do while your pain is tolerable. So making sure we have those really good conversations with our patients to manage the expectation of pain management, I think is super important, especially now that we're learning so much more and more about how these pain medications have long-term effects on our patients.
That's so true. I think managing expectations is something that can be applied across all nursing practice, but especially for pain management. It's really discouraging to hear doctors say, oh, yeah, you won't have any pain after your surgery. Like, no, that's not the case. You need to tell your patient that you will have pain, but we're going to try to the best of our ability to help meet those needs for you.
Oh, absolutely. And I have heard that before. I've heard doctors say, oh, don't worry, we'll take care of that. And then you're like, oh, okay, exactly. What's your plan to take care of that? Because you're here for 5 minutes. I'm here for the rest of the shift. And you weren't real clear on that. Like you didn't manage the patient's expectation with that. You just said, we'll take care of it. So and that can be incredibly frustrating when there is not a clear expectation between the physician and the patient, and then the nurse has to come in and be the bad guy. So really important that everybody on the care team is on the same page in terms of pain management so that you don't, right, have the nurses looking like the bad guy coming in and being like, well, sorry, I can page him, but ultimately I don't want him to change your orders because you're on the right ones, So yeah, that can be a setback, I think. But man, if you manage the expectations and you tell the patient all the things that they need to do so that they can go home and so that they can feel better, you really get one of two patients, right? You get the one patient that's motivated to do all the things that they're supposed to so they can get out of there. Or you get that other patient that can't cope, right? They don't cope well with what's happening to them. And so they end up laying in bed in misery. So whatever we can do to get number 2 to switch over to number 1, that's really the goal in managing our pain, is getting our patient to do what they're supposed to do, to get themselves in a position to go home and manage themselves without the reliance of a narcotic.
Nursing is as much as I feel like in a lot of ways spiritual work as it is clinical work and emotional work, trying to help meet our patients' spiritual needs, I have found really helps to mitigate some of the what we're lacking on the pain management front. So that's definitely something that works for me, being a healthy amount of emotional and spiritual support for our patients. Keyword healthy, guys. Make sure you have some boundaries in place
Exactly.
for your sake. But yeah, definitely meeting our patients' needs on those levels.
It's interesting. I remember learning about pain management in nursing school, and they always talked about a cultural aspect being to it. But in my practice, I never really saw that come to play. I never really saw one ethnic group over another complaining of more or less pain. In my practice, it was really more based on diagnosis. This diagnosis has more pain than that diagnosis. What about you, Chelsea? Have you seen the cultural aspect to pain complaint, or has yours been more diagnosis, or what is your experience with that?
Well, for me, it's definitely been more diagnostic. But one issue that I would like to bring up is, if any of our listeners have heard about this, would love for you to read up on it. But basically, the idea that Black people and also people of color have less pain than some other groups of people, like Caucasian folks. So just definitely make sure that you check your biases that you have on pain, especially when it comes to your Black patients or people of color. I know for me, that's definitely been a thing, unfortunately, where I have recognized that, hey, are we really meeting this patient's pain needs, or are we being biased, especially with our sickle cell patients? And I know that it can be frustrating, but their pain is valid and it's real.
I'm really glad you brought that up, because I have heard that before, that teaching, I should say. I've heard those lessons of people of color not experiencing pain the same way, or that their pain is not as intense. But for me, I think I held on harder to pain is what the patient says it is, and discarded those kind of teachings. I hope that my nursing colleagues out there that may be listening have done the same, of discarding that teaching and held on to the patient, what the patient reports, right? But I am really glad that you brought that up for anybody who maybe needed to check their biases, because that is really important, that we are not assuming that one group of people are experiencing it differently just because somebody said so. And there's no real scientific evidence to back that up. So I am glad that you brought that up. Well, it looks like we're running out of time here. I feel like pain management conversations could really go on and on. We do look forward to connecting with you on our next episode of med-surg Moments, the AMSN podcast. In the meantime, we want to hear from you. Send us your questions, topic ideas, and feedback via our official med-surg Moments email address. That's amsnpod@amsn.org. That's amsnpod@amsn.org.
We also like to remind you to become a member of the Academy of Medical Surgical Nurses, or review your membership at www.amsn.org. You receive lots of cool benefits and perks, such as discounted pricing on the annual convention and continuing education.
We encourage you to help us spread the word and subscribe to the med-surg Moments podcast via your smartphone podcast app to receive notifications of future episodes. Please be sure to leave us a review and recommend med-surg Moments wherever you get your podcasts to help us reach even more listeners.
We invite you to join the conversation by sharing your ideas and questions on AMSN's Facebook, Instagram, LinkedIn, or Twitter pages, and don't forget to add #med-surg Moments to your post. Simply enter AMSN on the search field of any of these social media platforms to connect with us.
The content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses. Until next time, I'm Alissa.
I'm Chelsea, and always remember, med-surg Moments is a moment in our lives, a moment in our med-surg careers that makes a huge difference.